Mhm. Uh, Hello, and today we have our third lecture on infectious disease. It is about acute intestinal infections, dehydration, principles of rehydration therapy. And we begin. Like, take your seats, take your coffee, and prepare to listen. So to begin with, we'll start with general characteristics of infectious diseases with fecal oral mechanism of transmission. They have a lot of common one, like particular localization of the causative agent in gastrointestinal tract, like small or large intestine, rectum, or mesenterium, depending on what the causative agent is and its tropicity. The movement of the agent with feces over meeting masses, penetrate in a susceptible organism in special ways of transmission, watery, alimentary, or contact household, various factors of transmission, maybe foodstuff, maybe water, maybe dirty hands, maybe insects or toys we would talk about, kids, or even soil. Different localization of the causative agent in the intestine, in lumen of intestine, on intestinal epithelium, on the mucous membrane, in lymphatic tissue of intestine. Causative agent can constantly be in intestine, like in cholera, dysentery, and some helminthic invasion, or temporary. The ability to penetrate from the intestine to the blood and other tissues, ascariasis, amoebiasis, tonsillidiasis, trichinosis, and echinococcosis, have this ability. The incidence of the infectious disease is higher in the warm and rainy periods, so it's summer or rainy season in tropics. In moderate climatic zone, it's usually summer and autumn. Or in countries with low socioeconomic level of development due to absence of central water supplies, for example, and problems with boiling water. Among people of risk group, age, children and the elderly. People with chronic GIT pathology, patient with gastritis cause lower acidity and less effective this barrier, duodenitis, peptic ulcers, cholecystitis, etc. Profession: sanitary workers, plumbers, teachers, medical personnel. Occupations: fishermen, water rescuers, veterinarians, and animal trainers. So what is diarrhea at all? Diarrhea is disorder of frequency, volume, and consistency of stool accompanied with abdominal pains, mostly. Disease with diarrheal syndrome are divided on 3 types. It's kind of more topic of 6 year, but it's helpful in understanding clinics in this part of intestinal infection. So type A, proceeding without an inflammation of intestine. Type B, proceeding with an inflammation of intestine. And type C, caused by short-term penetration of infectious agents through mucous membrane of intestine without damage. Type A, usually in small intestine, disorder of water and electrolyte absorption. Mucous membrane of intestine is not involved in the inflammation. At biopsy of intestine, morphological changes are insignificant or not found. General symptoms: fever, malaise, anorexia are moderate or absent. Typical symptoms: pain in mesogastrium, plentiful watery stool meteorism. In coprocytogram, leukocytes are not found because without inflammation. So there is, I don't know if this is a picture, so it's intestine. So normally water absorbed in intestine and stool goes rather slowly. In this type of diarrhea, water absorbed less efficiently, so more water in the stool and it passes much more fast and frequently. This type of diarrhea can be caused by viruses, rotavirus, parvovirus, toxigenic bacteria like Vibrio cholerae, Escherichia coli, Staphylococcus aureus, Bacillus cereus, and some parasites, Giardia intestinalis, Ascaris lumbricoides, cystodes, Ankylostoma duodenale, Stringloides circularis, Trichinella spiralis, Cryptosporidium parvum, and etc. Type B. Large intestine is involved and affected. Inflammation of intestinal wall. Infectious agents are implanted in a mucous membrane of the large intestine and damage it. General symptoms. Fever, malaise, anorexia are moderate or severe. Typical symptoms of colitis. Pain in hypogastrium. Painful spasm of large intestine. Tenesmus, which are painful spasm of the rectum that comes before defecation and relieves or goes away after it. In coprocytogram, we can see leukocytes, admixture of mucus and blood. Again, admixture, not bloody diarrhea, admixture of mucus and blood. Still is scanty, brown or pink, due to admixtures of blood maybe. This type of diarrhea is caused by bacteria like Shigella, Salmonella in its colitic form, Yersinia enterocolitica, Escherichia coli, some of its SAMs, Campylobacter jejuni, Clostridium difficile, some parasites like Escherichia, Entamoeba histolytica, Balantidium coli, or Schistosoma. Type C diarrhea is caused by penetration of infectious agent in mucous membrane and lymphatic tissue of intestine, usually small intestine without damage. General symptoms: fever, chills, headache, malaise, disordered sleep. Typical symptoms: diarrhea or constipation, mesodynitis, roseola spot rash bradycardia, hepatosplenomegaly, leukopenia. In coprocytogram, we can see macrophages. The classical example is Salmonella typhus that you already heard of on the last lecture. More rare, Yersinia enterocolitica, Campylobacter jejunum, Pseudomonas aeruginosa. Factors contributing to the development of diarrhea. The reduced acidity of gastric juice, yes, because it's the first barrier that should kill bacteria. Non-active intestinal peristaltics, yes, low excretion of bacteria. Imbalance of intestinal microflora. Insufficient levels of copper antibodies. Sometimes diarrhea can develop a non-specific response of human organism on the severe infection proceeding outside of the intestine, more often in newborns, but can be in adults caused by gram-negative microflora. The reason of non-infectious secretory diarrhea may be exogenous. After some, for example, medicine, purgatives, antacid of diuretics, antiasthmatic, cholinergic, cardiac, thyroid, antimetabolic drugs, prostaglandins, some toxins, errors of a diet, like if you never tried and first time you eat salty fish and milk, in a lot of people it causes rather express diarrhea. But some people won't react, but these errors of diet may cause something like this. Hypersensitivity of intestine without structural damage for some food. Endogenous. Congenital enzymopathy, maybe. Potassium diarrhea, absence of sodium, hydrogen in electrolytes. The functional distress of intestine. Cholanteritis, ulcerosis, ischemia, necrotization or hemorrhage. Pellagra. Metabolic diseases, hyperthyroidism, insufficiency of adrenal glands and pancreas, allergy, purpura Schleien-Genoch. Now, clinical variants of diarrhea and clinical criteria. Technically, we now kind of discuss salmonellosis and shigellosis, because in salmonella is typical enteritis. Well, actually gastroenteritis, but Typically, enteritis is like salmonella in the first place, and colitic in large intestine is typical shigellosis. Salmonellosis may be in gastroenterocolitic form, so then it will be combined with symptoms, and shigellosis may be in enteritic form, then it won't be typical, but typically salmonellosis is gastroenteritis and shigellosis is colitis. So frequency of stool in both time more than 3 times a day, so that's what we call diarrhea. Consistency. In enteric, it's watery and mushy, porridge-like, and in colitic, it's just mushy porridge-like, but it gets scanty. Volume, again, plentiful in enteric and scanty in colitic. Color, yellow, orange, green, or transparent, depends on the properties of pathogen in enteritic form, and brown, pink, or red in colitic form. Admixture, usually absent, sometimes little of mucus in enteritic form, and in colitic form is often a lot of mucus and blood-like streaks, so like admixtures of blood, not blood itself. Localization of pain. In enteritic form, it's epigastric in paraumbilical area. In colitic form, it's in hypogastrum and left iliac region. Character of the pain. It's colics and spasms in enteritic form, and cutting, cramping pain, tenesmus in colitic form. For example, salmonellosis, cholera, intestinal yersiniosis, and Escherichia coli infection, which is typical enteritic, and shigellosis, anabiasis, bronchiolitis, typical colitic. But cholera, it's not so typical because, again, in cholera is usually watery like water, transparent color, but pain in cholera is absent at all. Maybe some discomfort in the abdomen, maybe some mild pains or discomfort in the epigastric area due to vomiting, but again, colic, spasm, and pain in paraumbilical area in cholera is not typical. So if we talk about cholera, again, so there will be no pain, no inflammation, and mostly absence of temperature. All the clinic of cholera will be due to dehydration. And the severity of cholera is all about dehydration. And so criteria of degree of dehydration is how we define. So according to these symptoms that I'll say you a bit like maybe in 2 minutes, we can define the severity of cholera, mild, moderate, or severe form. So it's in the first place loss of body mass. If you know previous body mass, then you can just weigh the patient. Then you can count how many kilos he had lost, what percentage of his body mass it is, and just on the basis of it, say how many percentage he lost. But if you don't know exact weight, just according to this criteria, approximately you count. So, in loss of body mass, first degree 5%, up to 5%, yes. Second, up to 8%, like from 6 to 8, yes. Third degree, 9 and more percentage. Body temperature. In first degree, it may be usually normal or subfebrile, up to 37.5. It's usually in cats, it may be subfebrile, and in adults, absence of temperature, but again, some subfebrile temperature may be not febrile, yes, not 38, not 39. Second degree, 36.5 up to 37, not higher, and in the third degree, it is less than 36.6, less than normal temperature. Rate of stool. In first degree, it up to 15 times. Second, 20 to 25 times. Third degree, more than 25 times or absent. Not because everything is okay, because everything is bad. Yes, like lack of water is nothing to defecate anymore. Frequency of vomiting in first degree up to 10 times, second degree 10, 20 times, third more than 20 times or again absent. Pulse rate. First degree it's normal, maybe about 80 beats per minute. Second degree tachycardia, increased pulse up to 120 beats per minute. And in third degree it's more than 120 beats per minute and it's weak. It's hard to count maybe even. Blood pressure, normal in first degree. Second degree decreased, less than 90 to 70. In third degree, less than 80 to 60, or maybe even, well, less than, so it may be 70 to 40 or even 40 to 0. It's dependent on, like, is it 9% to 10% or even more. Daily diuresis, normal in first degree. In second degree, allegorrhea, adds. In third degree, up to anuria. I remind you that allegorrhea is volume of daily urine less than 500 milliliters. In anuria, volume of daily urine is less than 50 milliliters. Yeah, so if 20 milliliter is present, it's still anuria, not allegorrhea. Cyanosis. Absent or just pale skin in first degree of dehydration. In second degree, acute cyanosis, yes, just some fingers. And in third degree, total cyanosis of the person. Skill, elasticity, and turgor, normal in first degree. In second degree, it's decreased and significantly decreased in third degree. Muscle cramps, in first degree, absent at all. In second degree, it's 1-2 group of muscles, and generalized muscle cramps in third degree. So again, it's not abdominal cramps as in other intestinal infections. Yes, it's muscle cramps of skeleton muscles, like legs, for example. It usually starts with legs, then hands, and it's due to acidosis and lack of some ions. Yes, not to other factors as in, for example, shigellosis. Yes, muscle cramps of skeleton muscles. Sonority of voice. It will be already weakened in the first degree, maybe a bit, and the second degree, hoarseness of the voice, and aphonia in third degree. Thirst and dryness of the mucous membrane, moderate or absent in the first degree. Expressed thirst and expressed dryness of mucous membrane is the second degree. You could just ask a person to show their tongue, and already it's like dryish. And the most severe in the third degree, of course. Hematocrit up to 45 in first degree, up to 65 in second degree, more than 65 in third degree. Electrolyte shift in the blood, decrease of potassium in first degree. Decrease of potassium is more expressed and adds decrease of sodium in second degree. Most expressed decrease of potassium and sodium in third degree. When we talk about treatment of cholera, in the first place, it is about rehydration. Antibiotics is on second place, and in mild forms, they're not even recommended by World Health Organization. But again, in the first place, it's rehydration. Because if you won't start it immediately, sometimes it may mean that your patient won't survive until you prescribe him some antibiotics. Yes, so rehydration saves lives in a cholera, especially when we talk about severe form, well, at least moderate severity. So rehydration is divided in primarily and compensatory. Primary is replacement of fluids that lost before hospitalization. And compensatory is recovery of continuum water and electrolyte losses during hospitalization. Yes, when you hospitalize the person, it doesn't mean the moment he got in the hospital, he became cured. No, he can have a vomiting and diarrhea of 2, 3, and more days, and these compensatory losses you should restore. again, it's mostly about cholera, but again, if we talk of any intestinal infection with dehydration, yes, you should count. For example, you have toxic foodborne infection, yes, your patient. So, of course, this was short. So, but the first day was expressed diarrhea and vomiting and high temperature, and person got to your clinics, and you gave him a lot of fluids and intravenous and per orally the first day. On the second day, he had diarrhea like 2 times. Yes, not a big loss, so maybe even intravenous infusion is not that obligatory, and you can just give him plentiful drinking. But if we talk about, for example, salmonellosis, and on the third day, person still have 7 times diarrhea, plentiful, and maybe 2 times vomiting, yes, maybe at least liter you should give him. Yes, it's plus plentiful drinking. So intravenous infusion is still necessary and obligatory because compensatory as its losses still continued during hospitalization. That's what does it mean? So rules of primary rehydration. Yes, your first treatment, your first infusion. Duration 2 to 4 hours. Except for elderly children and patients with chronic pathology of the cardiovascular system, elementary cachexia, then it's 6 to 8 hours because their cardiovascular system is not that strong. Yes? And it can cause complication, iatrogenic. To restore the balance of electrolytes, it is necessary to determine the volume of the lost fluid. To do this, you need to know the body weight and the degree of dehydration in person. To weigh the patient body mass minus body weight regarding the existing clinical symptoms, comparing the previous table, to determine the degree of dehydration according to WHO classification in percentage. So the easiest way method is volume of the lost fluid is calculated by the formula body mass multiplying on percentage of body mass dividing body mass lost. Yes, divided on 100%, then we got the volume of the fluids you should give to the patient. To determine the method of introduction of fluid, oral or parenteral. In oral, first and second degree of dehydration without vomiting. It's then we'll give it oral. And volume multiplies on 1.5. It's a constant to characterize the ratio between the volume of fluid introduced in intestine and absorbed into the blood. If person have vomiting, even in the first, for some reason, when you talk about, for example, toxic foodborne infection, when vomiting prevails. Yes, until vomiting stopped, you give this intravenously. Oral solutions that we can give is rehydron, glucosalan, citroglucosalan. Mix it. First and second degree vomiting till 3 times per day. Oral 2/3 of volume multiplied on constanta 1.5. Parenteral 1/3 of volume intravenous. So if it's, for example, you count that your person needs 3 liters, 1 liter you give intravenously, 2 liter, no, even 3 liters, because 2 multiplied on 1.5, then 2 multiplied on 1.5, it will be 3 liters. Yes, you give orally. Parenteral, first and second degree without vomiting, with vomiting, sorry. First and second degree with vomiting more than 3 times a day, or third degree dehydration just intravenously. Choice of infusion solution depends on the level of potassium in the blood of the patient. So if it's less than 2 millimole per liter, you use quatrasol. If it's about 3 millimole per liter, you give trisol. If it's more than 3.5 up to normal, you give disol. To determine the speed of intravenous infusion, first degree 60-80 drops per minute, it's usual speed. Second degree, 100 to 120 drops per minute. And third degree by stream, because again, life-threatening cases. To stop, you can stop intravenous rehydration if there is no vomiting, constant normal pulse and blood pressure, daily diuresis exceeds the daily stool volume in 1.5 times. Yes, so mostly water goes away with urine, not with the stool. Yes, it's how we stop intravenous rehydration and maybe continue only in oral. Yes, stop of vomiting, daily diuresis exceeds daily stool volume in 1.5, constant or normal pulse and blood pressure. So now go into more detail about salmonellosis. It's acute intestinal zooanthroponotic infection with fecal-oral mechanism of transmission described by a preferred lesion of small intestine and developed on severe intoxication and diarrhea in the clinic. Etiology: family Enterobacteriaceae, genus Salmonella, includes 1 species, 7 subspecies, and 2,300 serotypes. Gram-negative motile rows without spores, has 4 antigen: O, somatic antigen, lipopolysaccharide; H, flagellal antigen; K, capsular antigen, facilitates infiltration salmonella inside of enterocytes; V, virulence antigen. Produces enterotoxin, causes a diarrhea, activation of CAMP; cytotoxin, destroys the membrane of the cell, disrupting the synthesis of proteins; hyaluronidazole, neuraminidase, eryplasmide that cause resistance; releases antitoxin, lipopolysaccharide, the complex cellular of the wall, causes a set of toxic symptoms; grows well on usual mediums; stable in environment, in water up to 5 months, in milk up to 300 days, at temperature 18-24 degree up to 80 days. It's rather sensitive. Usual concentrations of disinfectants inactivated in 30 minutes. The boiling perish immediately. The factor of pathogenicity: ability to endocellular parasitism, K antigen promoting the infiltration, eryplasmide resistance to antibiotics, presence of aggressive enzymes, ability to cause bacteremia and sepsis, ability to reproduce in many bodies, ability to cause dysbiosis, ability to derivate L form, presence of toxins. Epidemiology: source of infection: warm-blooded animals, swimming birds, if we talk about animals. If we talk about people, the patient with manifested form of the disease, and carriers, especially chronic carriers. Yes, zooanthroponotic, both animal and human may be infection. Mechanism of transmission: fecal-oral. Routes of transmission: elementary watery contact. Factors of transmission: foodstuffs, meat, lactic products, eggs, fish, contaminated water, dust, egg processing skin animals, contact with subject of environment. Risk groups: children till 2-5 years, old people, people with chronic GIT pathology, immunocompromised person. It's a risk group of severe course. Yes, all people are susceptible, but this group has more severe course. Seasonal prevalence: summer, autumn. And about foodstuffs, meat, lactic products, egg or fish depends on food habits of the country. Yes, like in Russia, it's rather popular to drink raw eggs, which is not typical in some other countries. So in Russia, we always ask about eggs. in countries where some unprocessed fish is more spread, it may be more often fish or something like this. Pathogenesis. Penetration of Salmonella through a mouse in stomach. Mass destruction with excretion of endo and exotoxin, this causes toxemia. Entering in small intestine, infiltration through enterocytes, colony, reproduction and accumulation. Activation of CAMP, appearance of a secretory diarrhea. The detraction of Salmonella at this stage causes only localized form with subsequent recovery. Then bacteremia at gastrointestinal form is short-term, maybe, but it incompetence of immunity, Salmonella can penetrate into blood and causes hematosepsis, one of the form. Clinical classification. Yes, it may be localized form, gastritic, yes, with clinical gastritis. Gastroenteritic, which is the most common, with from its vomiting and watery diarrhea. Gastroenterocolitic, vomiting, watery diarrhea, plus maybe a mucus of admixtures of mucus, for example, maybe even blood. Enterocolitic, yes, without vomiting, but more of colitic syndrome. Generalized may be influenza-like, typhus-like, and septicopyemic, yes, when it goes to blood. Also, it always may be mild, moderate, and severe form. Severity of salmonellosis is a bit different to severity of cholera because it's add with pain in the abdomen with abdominal cramps plus temperature, yes, which is absent in cholera. So, duration of fever in mild form 1 to 2 days, in moderate form 3 to 6 days, in severe form more than a week. High fever in mild form up to 38, so it may be 37 and 2, for example. Moderate up to 39, and severe 39 and more. It may be 40, it may be even 41. Duration of diarrhea up to 3 days in mild form, 4 to 10 days in moderate form, and more than 11 days in severe form. The frequency of stool up to 5 times per day is already mild form, 6 to 10 in moderate form, more than 11 in severe form. Frequency of vomiting 0 to 1 mild form, 2 to 4 times a day moderate form, 5 and more times per day it's severe form. Blood pressure normal and mild form, up to 90 in moderate form, 80 in low and severe form. Pulse rate up to 100 in mild, up to 120 in moderate, more than 120 in severe. Yes, this is similar to cholera. Laboratory inspection. Specific test for confirmation. In the first place, bacteriologic research. It's bacteriological culture of feces, vomiting masses, gastric lavage in localized form, blood, urine, bile, and liquor may be taken in generalized form. So if person have gastroenteritis, there is no way to take his liquor or blood. In generalized form, you may test it. Right? Medium may be chloric broth, salinity nutrition, bismuth sulfas. Serological test, EHA test, CF test, ELISA test, immunofluorescence, detection of antigens of Salmonella in copper filtrates. It's rapid test, express diagnosis. Non-specific investigation. In CBC, you will see neutrophilia, azinapnea, shift to the left, acceleration of ESR. In urea analysis, you may see signs of set of symptoms, toxic kidney. Treatment. Specific therapy, not indicated for localized forms. Antibiotics should be given to the patient of risk groups and generalized form, like for example, elderly, yes, or in generalized form. Quinolones, ciprofloxacin 0 5 grams, 500 milligrams twice a day. Aflatoxin 400 milligrams twice a day. Chloramphenicol may be given 500 milligrams 4 times a day, but it's antibiotic of reserve. So if quinolones not working, and sometimes Salmonella already resistant to ciprofloxacin and ceftriaxone and so on. Cephalosporins of the third generation, ampicillinum, amoxicillin, amikacinum. Non-specific therapy. Detoxification per orally or intravenously. Lavage stomach of intestine, enterosorbents, plentiful drink. Yes, enterosorbents, don't forget it. Rehydration per orally or intravenous. Metabolites, angioprotectors may be used. Ferment drugs may be used. Biological preparation and infectious toxic shock, which is may be here too. Yes, as we talk about possibility of a generalized form. Yes, bacteria in the blood. Of course, we talk about possibility of infectious toxic shock. Glucocorticoids may be used. Discharge from hospital only at clinical convalescence. One negative bacteriological test of the feces in second day after ending treatment. Decree group will need 2 negative bacteriological tests with a subsequent observation 3 months with monthly bacteriological test. It's like people who work as a cook, who work as waiters, or like sellers of food products. Cholera. Acute intestinal infectious disease with fecal-oral mechanism of transmission, saproanthroponosis, characterized by functional disorder of enterocytes, development of dehydration and demineralization, clinically manifested by severe diarrhea syndrome. It is typical disease with diarrhea of A type. Etiology. Vibrio cholera is present in 2 species, Vibrio cholera biovar L-tor and Vibrio cholera biovar cholera. The new strain Bengal O139 causes diarrhea of people but not agglutinate with 0,1 group antiserum. It is resistant to streptomycin and cotrimoxazole. Now it belongs to the 3rd biotype. That's how it looks like, polariflagellum. Characteristic. Small, gram-negative, comma-shaped rods, size 1.5 to 4 microns of length and 0.2 to 0.4 microns of wideness. Mobile, have flagella, the most mobile between pathogenic infectious agent, has no spores and capsules, facultative aerobes, gallophyll. Grows on the simple alkaline media with pH of 7.8 up to 8. Feature: thermostable antitoxin. Thermolabile antitoxin calorigen provides a development of dehydration. Factors of aggressiveness: neuraminidase, lipase, protease, H antigen, O antigen. So group O1 is divided into Inaba, Agava, and Higashima. Resistance: high in water, humid environment a few months, in foodstuff for 2 to 5 days. Sensitivity to the dryness, ultraviolet radiation, disinfectant, high temperature, boiling, antibiotic, tetracycline, ampicillin, chloramphenicol. Halophils. Optimal pH of nutrition medium, it's about 8. They are easily coloring by all aniline stains, well grown on simple medium, like 1% of peptonic water. Stability in the external environment, survival rate. In seawater, up to 2 months, L-tor. In subject of use, up to 7 days. In fresh water, up to 18 days. In milk, up to 2 weeks. On vegetables, up to 10 days. In refreshing sea products, up to 14 days. In the freezer, up to 3 weeks. Epidemiology. Source: Vibrio carrier, more dangerous in epidemiological chronic form. Patient with clinically manifested form, especially in the first 4 to 5 days. Patient with obliterated form, convalescence within 2-4 weeks. In the first day of the disease, the patient discharges about more than 1 million fibrosis. Mechanism of transmission. Fecal oral released by watery way is leading, drinking basin, alimentary, milk or rice, and contact also may be. Susceptibility, general and high, depends on the season, active drinking basin flies, age, elderly and children, persons with GIT pathology like hepatic gastritis, anemia, and helminthiasis, like we told before. Immunity, resistance, specific, antitoxic. Morbidity high due to fast distribution, 1 to 3%. Due to wide application of pathogenic treatment, rehydration, the mortality from cholera has decreased significantly. But prognosis is always serious as a dehydration of third, fourth degree. Recently, the mortality rate decreased from 6 to 1%. Again, it's more about treatment. If it's okay, then. So it's rather old slide. It's about spreading of cholera in 90s. It is rather spread. Now it's much less spread, but still present, and outbreaks is happening from time to time. Now a bit about pathogenesis. Cholera toxins, they go into cells and increase adenosylcyclase activity and CMP, and then diarrhea goes due to loss of potassium, sodium, chloride, water, and carbones. The factors of Vibrio pathogenicity facilitating the process of colonization. Flagella adds mobility to Vibros. So the factors of Vibrio pathogenicity facilitating the process of colonization. Flagella adds mobility to Vibros. The mutinates dilute slime on the surface of enterocytes, facilitating fixation of axitoxin on receptors. GM1, ganglioside, hyaluronidase and neuraminidase facilitates infiltration of axitoxin in enterocytes. Other toxic component, hemolysin, Fultor, etc. So again, how it's go? I know what's the start again. Colonization of intestinal epithelium, multiplication on the surface of epithelium, virulence proprotease cause diarrhea. This diarrhea persistent in aquatic reservoirs with biofilms, like on like lakes or rivers even. Then people drink oral ingestion, passage through the gastric and acid barrier. Biofilm protects against acid shock, and so it goes then to colonization. Yes, so let's maybe start with the oral ingestion, going through barrier, and this biofilm protects then colonization, and again the cycle repeats. So it's pathogenesis in words. Scheme of pathogenesis of cholera has the following steps: ingestion of Vibrio cholera in the intestine, reproduction in an alkaline environment and destruction, the release and accumulation of toxins, including cholera again, increased secretion of isotonic fluids. Cholera again activates CIMF on membranes and enterocytes, increases a permeability of enterocyte membranes for sodium and water, blocks the sodium pump and reduces the resorption of isotonic fluids, then dehydration comes in severe form, hemaconcentration, slowing blood flow, hypoxemia and hypoxia, metabolic acidosis with the accumulation of toxic products, extra-renal urinary disorders up to anuria in severe cases, or extra-renal coma. Pathomorphology. Yes, if person died during this, so what we see on autopsy? Biopsy of the small intestine. swelling of the basal layer of the mucosa and the endothelium of blood vessels. Structure of enterocyte is not violated. Sight-on functional hyperactivity, enteritis, are not developed. At the autopsy, severe dehydration of all tissues, ischemia of mucosa in stomach, small intestine and colon if swollen with small hemorrhages. In all perihematose organ express dystrophic changes. Clinical classification. Again, every disease has mild, moderate, and severe course. May be complicated, uncomplicated. It may be in typical, as we told before, and atypical form, which is subclinical erased or erased form, dry, so-called dry cholera without vomiting and diarrhea but still dehydration, hemorrhagic cholera, gastric cholera, and mixed. Incubation, 2 to 3 days, average, but from several hours to 5 days. Prodromal period is not typical, but sometimes may be feeling of anxiety, weakness, rumbling in abdomen, pain in chewing and cough muscles, sweating, dizziness, cold extremities. In climax of disease, in typical cases, disease begins suddenly, more often at the night or before morning with acute diarrhea, but without abdominal pain and tenesmus. Stool quickly becomes watery and then resembles rice water, loses its odor and becomes the smell of raw fish or grated potatoes. The patient feels discomfort in epigastric or paraumbilical area. Again, discomfort, not pain, not cramps, just discomfort. Yes? Rumbling around the navel, murmurs in the abdomen, feeling of bloating, insuperable desire of defecation. After a few hours, sometimes a day, diarrhea accompanied with repeated vomiting, sometimes a fontaine, without nausea. Yes, it's clinical characteristic. Vomiting without nausea. In most other intestinal infections, vomiting and nausea goes alone. Here, vomiting without nausea. Vomit quickly becomes watery and resembles rice water. Profuse diarrhea, repeated vomiting lead to dehydration. Intoxication have endogenous characters, not due to some antitoxin like in salmonellosis or typhoid fever, but due to endogenous process. Weakness, thirst, dryness in the mouth. The skin becomes bluish, cold, and loses its elasticity, turgor. Here is how skin with decreased turgor remains elevated after being pulled up and released. This is in dehydration. Then, tongue is dry, abdomen is retracted, painless, but possible meteorism due to hypokalemia. Voice become hoarse, breathing quickness, tachypnea, tachycardia and decreased blood pressure develop, reduced diuresis, convulsions of some group of muscles, consciousness is not changed, patient indifferent, feels fear. Body temperature remains normal or even decreased in severe cases. CBC without significant changes, but hammer concentration may be. In severe forms. Severity of the disease is determined by the degree of dehydration, hemodynamic and metabolic disorders. Atypical form. Fulminant cholera due to reproduction and accumulation of fibroa in biliary tract, small intestine and penetration of its toxin to the blood in high concentration. Sudden onset and rapid development of dehydration. Fast development of hypovolemic shock, convulsion of muscle groups, systems of encephalitis and coma. Dry cholera or cholera zika is very severe, tragic form of the disease with a malignant course. severe weakness, rapid development of collapse, dyspnea, confusion, cyanosis, coma. This form of disease is rare, usually in malnourished patients. Obliterated cholera is characterized by unclear symptoms and mild severity, often observed in case of cholera and TOR. The basic clinical diagnostic symptoms of cholera. Classic tetrad: diarrhea, vomiting, dehydration, isotonic, and cirrhosis. Acute onset of illness with diarrhea and following vomiting. Yes, never starts with vomiting. Diarrhea is following vomiting. Without nausea, without abdominal pain, and without abdominal cramps. Yes. Vomit and feces is a form of rice water, subnormal or normal body temperature, acrid cyanosis or total cyanosis. The symptoms of cholera phase: hands of washerwoman, yes, like this, cholera folds, cholera glasses, hoarse voice or aphonia, tachypnea, tachycardia, decreased blood pressure, collapse, and oligonuria. Specific diagnosis of cholera. Bacteriological method. Classical, main in laboratory diagnosis of cholera. For bacteriological study using feces and vomit, 10-20 milliliters and 1% peptone water. Serologic method. Immobilized reaction of immobilization, microagglutination of Vibrio cholerae by O serum, constant microscopy, result in a few minutes, reaction of immunofluorescence, result in 2-4 hours, RIHA, RN, ELISA. Non-specific diagnostic. CBC plus hematocrit, relative leukocytosis, shift formula to the left, increased ASR and hematocrit, HAMA concentration. So it may be increase in hemoglobin, increased in erythrocyte, increased in thrombocytes, but it's all due to HAMA concentration. Urinalysis may be leukocyturia, proteinuria, microhematuria, mixture of. Okay. So this is how they look like in the microscopy, Vibrio cholera. And now treatment. So in the first place, non-specific therapy, rehydration, oral or parenteral. The use of cardiac glycosides is contradicted due to increased disturbance of microcirculation, assisting in the development of kidney failure. Diet number 4, and in 3-4 days with a predominance of food and that contain a lot of potassium, like potatoes, for example. Pro and abiotic sorbents. It's non-specific. Specific therapy. So, the principle of antibiotic therapy of cholera. Administration of antibiotic after obtaining material for bacteriological examination. Yes, first take vomiting masses and stools, then give antibiotics. Continuity of the drug, including night hours. Parenteral uses of antibiotic till disappearance of vomiting, after that in oral form. Determine susceptibility to antibiotics. Treatment with antibiotics, regardless of the degree of dehydration, should be at least 5 days. So this is how people are treated. So it's in Peru was an outbreak, so they're just sitting and get the intravenous infusion. Antibacterial therapy. So what we use? Doxycycline, 100 milligrams twice a day per oral. Tetracycline, 500 milligrams 3 times a day per oral. Biceptolone, 960 milligrams 3-4 times a day. Furosemide may be given 100 milligrams 4 times a day, or ciprofloxacin, 500 milligrams 2-3 times a day. Usually doxycycline and ciprofloxacin are the drugs of choices. quinolones and cephalosporin to the third generation. Rules of discharging from the hospital. Patient discharged from hospital after receiving negative results of bacteriological examination, which is taken before discharge, 24-36 hours after the treatment with antibiotics. Complete convalescence, plus 3 negative tests of feces and 1 negative test of bile, so we can be sure person is not carrier, he is safe for the surrounding. Prophylaxis. In the first place, personal hygiene, improvement of sanitary condition of the external environment, use only high-quality water, vaccination forms antibacterial and antitoxic immunity, but does not influence on spreading of cholera and consistently in the present the time widely does not use. So it's only used if you like travel to cholera region and maybe want to protect a bit. Yeah, increase your chances. Person who will in close contact with cholera patient need immediate prevention. For this purpose, we may use tetracycline in dose 300 milligrams 3 times a day for 4 days. The dose for children is used in accordance with age. Well, that is all about cholera, salmonellosis, and degree of dehydration for today. So see you on the next lecture in the same time, and wish you good luck.